Hello everybody, and today we're going to talk about the role of ultrasound in the evaluation of deep vein thrombosis. So most people are very familiar with this sort of algorithm, and this is our usual approach to a patient with a potential DVT. We generally will apply some sort of clinical pretest probability, such as a Wells criteria or something, to divide patients into low and high risk groups. Those who are high risk will go immediately onto some form of imaging. Those that are low risk, we may well perform a D-dimer test, and if that is negative, we don't do any imaging. If it is positive, we then do go on to imaging. When we look at how this is applied in practice, though, what we've noticed over a number of years is that we are now testing larger and larger numbers of people. And because both the clinical test and the D-dimer are designed to be highly sensitive but have a low specificity, what this results in is that there are a large number of patients who are referred for some form of imaging. And in almost everywhere, ultrasound is the imaging modality of choice. And the reason why for this is that it's a very good test. It's very accurate. If we look, for example, in proximal leg veins, which is what we're going to concentrate on today, it's both very sensitive and very specific. But one of the things that you do need to remember is that in other areas, it's not actually quite so good. And in particular, if we start looking at the calf veins, the sensitivity drops to only 50 or 60%. The specificity is still very high, but there is a high rate of incomplete examinations. Similarly, it's not quite as good, it's more technically challenging if we're looking at upper limb DVTs as well. But ultrasound has all the advantages when looking for thrombosis as it does when being used looking for other disorders, in that it is non-invasive. It is certainly a lot cheaper than CT venography and MRI. It doesn't involve contrast media, and it may well demonstrate some alternative diagnoses, such as Baker's cysts, cellulitis, muscle haematomas, these sorts of things. So when we are looking for thrombosis, there are a number of ultrasound features that we look for. We're going to concentrate on the first two, the grayscale appearance and compression, but we're also going to talk about some of the Doppler features, colour flow, respiratory variation, and augmentation. So, grayscale. So this is the normal 2D image that you're going to look at, and normally veins are anechoic. The blood that's within them doesn't give any reflection, they look black. When there's clot, that clot is usually grey in colour. Initially it may be only very slightly echoic and it appears almost black, and then with time it can develop some increased echogenicity and it can become isoechoic. As it becomes chronic, it actually can become hyperechoic compared to the surrounding tissues. But fresh clot also causes the vein to be distended and swollen, and as the blood tries to find other ways around that blockage, you may see dilation of collateral venous channels. So this is what it looks like. Here we have the femoral vein, which normally should be black, and we can see in here there's all this echogenic material. Here is the deep femoral vein, or the profunda femoris as it used to be called, and once again this is full of echogenic material. It's a little hypoechoic to the surrounding tissue. That and the fact that the veins look distended and swollen suggests that this is an acute thrombus. There's also a colour box on, which we'll discuss later, but there is no colour flow in this area. So the gold standard that we use when trying to exclude the presence of thrombus is we look for compressibility. And if you can demonstrate complete compression of a vein, then you can say very confidently that there is no thrombus within that vein. And what you need to do is put enough pressure on to get the opposing walls to touch. If the vessel is full of blood, the blood of course will move out the way and you can compress veins quite easily. But if there's clot in there, although the clot may compress a little bit, you'll never manage to get the opposing walls to touch. And what we do as we do this is we follow the vessel course and we compress every 1 to 2 centimetres along the entire course of the vessel. So this is what a normal vein looks like, and most people are familiar with this because when you're placing central lines you use compression to ensure that you're looking at the vein and not the artery. So here we have the femoral artery, which is already divided. Here's the deep femoral artery branch here. Here we have the femoral vein, and with compression you can see the walls oppose, the vein completely collapses. When we look on the other side in this patient, what we see here is the artery, and here is the vein, and even though there's enough pressure to make the artery partially compress, the vein is not compressing at all. We also look here, this is the saphenous vein, and we can see that that too shows lack of compression. So this is a venous thrombosis in the common femoral vein and also in the proximal saphenous vein. And as I said, this is the most accurate test if you can perform compression adequately to exclude thrombus in the vein or to diagnose it. So these are some still images, and normally this is how we would record the images. You can get a loop if you like, but we take an image showing the uncompressed picture and then we apply compression, and in this case we've noted this to reinforce that there is absence of the normal compression, and that is diagnostic of a deep vein thrombosis. So sometimes, as well as that, we'll also use colour flow. Now, we don't tend to use this in the areas that we can easily compress the vein, but we can use it as an adjunct. And so if we're looking at lower leg thrombosis, then we'll use this to look at the external iliac vein, because we can't actually compress it while it's in the pelvis. So we'll have the probe right up in the groin, we take a longitudinal view along the vein, and then we put the colour box on. And what we hope to see is that there is colour flow filling the entire vein from wall to wall. If there is partial occlusion, then there might still be some flow through there, but there will not be flow through the area where the clot is. Now, this technique is not as accurate as compression for a couple of reasons. One is I may have my gain too low, in which case I won't see colour flow when there is flow, or I may have the gain too high, in which case the colour image will spill out of the area of actual flow to cover other areas. But so long as we get our adjustments right, this is fairly accurate. And so this is what we hope to see. Here we have the common femoral vein running over the femoral head, which we can see here, and into the pelvis where it becomes the external iliac vein, and we show nice colour filling of that entire vein there. Here, this is a patient who was actually transferred with a query ischemic leg. It was swollen, mottled and painful, and here we see in the region that we should be seeing the vein, first of all, is there's no anechoic vessel. We can see the grey scale material here, and there is no flow in here. I've actually turned the gain up enough so I'm starting to get a little bit of artefact because my gain's so high, just to prove that it's not that it's undergained. In this example, we can see here is some flow, but the flow doesn't extend over this area here. And this is because this is a partially occlusive thrombus, and so there is flow in the remainder of the patent lumen, but no flow through this area here. So as well as looking for colour flow, we can also use Doppler with some manoeuvres to again give us some extra information, although these are not usually our primary diagnostic modalities. We can do what's called augmentation, and in this we squeeze a peripheral part, such as the calf, or if you're looking in the upper limb, the forearm, and what that should do is create a pressure wave and result in a sort of a column of blood shooting up through that vein. Now that can be useful in a couple of situations. First is, if you're struggling to find where the vein is, and you do this, you may then be able to detect where the vein is. This might be helpful, say, in a very large leg with a lot of swelling and edema, where everything's really deep and you're not getting good clear pictures. Now, if we do this and we see prompt augmentation, then that suggests that that pressure is being transmitted very freely and the blood is flowing very freely between where we squeeze and where we have the probe. And that suggests that there's no major obstruction between those 2 points. It also suggests that there's no major obstruction more proximally because the blood is able to flow freely past the point of where you have the probe. So this can be quite useful to get a good overview as to whether there's a major obstruction in the system. And also it's particularly useful for those areas where you're unable to compress the vein, such as if you're looking at the external iliac vessels or if you're looking at the subclavian vessels. So what does this look like? Well, this is from a young chap who presented with a swollen right arm. And if we have a look at the left, the normal side for comparison, this is his subclavian, and we can see here this is the normal venous pressure changes that are seen in the central veins. Here we've squeezed his forearm, and then we can see a big rush of blood which comes here. It actually then wraps around onto this side of the scale, and this is the big squirt of blood that's gone through and then returning back to the normal venous pressure form. If we look, however, on the right side, the swollen side, first of all we can see that there's loss of that normal flow, and then with augmentation all we see is this very small increase in blood flow at that point. And that was due to a almost complete obstruction of his subclavian vein, so proximal to where we had the probe situated in this image. Now, as well as augmentation, we can also look for the changes due to respiratory variation. And these are really a reflection of the transmission of the interthoracic pressures and the changes that that has on the blood vessels. You tend to see these on the more proximal, larger veins. You don't tend to see them in the more distal and smaller veins. But what this again suggests, if you see this, is that there is free transmission of those pressures and therefore no major obstruction between where you've got your probe, for example in the groin, and the thorax. The one thing to remember about this though is that the loss of respiratory variation may be due to a more proximal thrombus, but also it can occur if you've got extrinsic compression of, for example, the inferior vena cava, and it also becomes blunted in congestive cardiac failure. So these things are nice to look for, but if they appear abnormal, then it requires a lot more investigation to work out exactly what the cause of it is. But they are ancillary tests. If we're looking purely for proximal leg DVT, we'll show you in the workshop how to do these, but they're not going to be the mainstay of your diagnosis. So let's get on to how do we actually do the exam itself, and I'm going to concentrate mainly on the lower leg, but the principles apply to wherever this is done. As with everything else, first of all, we have to select our probe and preset. We have to work out how to position our patient, and then there's a couple of different ways we might look at getting the images. So in general, as with everything else, we will tend to pick the probe with the highest frequency in order to get the better resolution, but that will give us adequate penetration. And so one of the things that you'll find is that in patients who are obese or have swollen legs, that your linear high frequency probe often will not give you enough depth. And so often we'll use the abdominal probe. But when I choose the abdominal probe, I'll often choose, say, the higher frequency within that range. So instead of being on 3 megahertz for the abdomen, I'll select the 5 megahertz and use that to look at the leg. Check that your presets when you're looking at your Doppler images are set for venous flow, because if they're set for arterial flow, then the lower velocity in the vein may not show up. In practice, for most adult legs, I'll actually use the abdominal probe set at the higher frequency range. So, just to remind ourselves of the anatomy of the leg, this side shows the superficial venous anatomy, and this shows the deep venous anatomy. So we have the femoral vein, we have the long saphenous vein that runs medially from the saphenofemoral junction down. You'll have to forgive me, strictly speaking anatomically, veins of course run distally to proximally, but I tend to think of this the way I scan, which is proximal to distal. The short saphenous vein we don't tend to look at much, but it runs into the back of the popliteal fossa. Looking at the deep vein system, we have the common femoral vein. It then gives off the deep femoral, or what used to be called the profunda femoris, and continues as the femoral vein. This used to be called the superficial femoral vein. That term is no longer used because it was confusing, because although it was called the superficial femoral vein, it was actually a deep vein. So now we just refer to it as the femoral vein. It runs down the leg through the adductor canal where it becomes the popliteal vein behind the knee. Further down, it's usually described as going to the trifurcation, but in actual fact it's usually a series of two bifurcations to give off the anterior tibial vessels, and then divides to give the posterior tibial and the peroneal vessels. And in the calf, these are usually paired veins, so there's actually 6 veins in the calf region, which is one of the reasons it's much more complicated to scan the calf than the upper leg. Looking at the cross-sectional anatomy here, just to remind everybody, we have the femoral artery, and medial we have the femoral vein. As we come down the leg, we have the femur here, we have the artery and the vein sitting underneath the quadriceps and the adductor muscles. And then after the vessel has passed through the adductor canal, it lies superficial to the artery behind the knee. So when we're scanning and we have the probe underneath the knee, the vein actually appears at the top of the screen. Now I'm going to mention very quickly about scanning the calf, only to say that this is technically much more difficult than looking at the veins more proximally. And even though we say use the term above knee DVT, we actually include the popliteal vein, so down to the distal popliteal vein, which is actually just below the knee. As I mentioned, the trifurcation isn't really a trifurcation. There are 6 veins, they are much smaller, they're often quite difficult to image. And so technically this takes a lot more skill and a lot more time. So if we're looking at proximal leg DVT, we will generally start up at the groin crease with our probe anterior, and we find the femoral artery and the femoral vein. We then slowly scan down past the saphenofemoral junction, continuing on the common femoral vein to where the profunda femoris or the deep vein joins, and then as we come down we may bring our probe round a little more anteromedially. We have the thigh or the leg slightly externally rotated. Now often there's a temptation to bring the probe very medially, but you'll find if you do that you often pick up edge artifact from the edge of the quadriceps, and so sometimes you're better off keeping the probe a little more anteriorly, using the quadriceps as a window, and compress the vein with your other hand from below. We'll demonstrate all this in the workshop for you, so you'll know exactly what I mean. Once the vein has gone through the adductor canal, then we put the probe posteriorly behind the knee and we look at the popliteal vein. You'll often find compression here is quite difficult because of the insertions of the hamstrings and the adductor muscles, and so you may have to tilt your probe a little bit so you can get enough pressure in there. In general, I will always try and get the veins to be as full as possible to do this exam because it makes them easier to see. And so I tilt the bed, and I'll tilt that up to 20 or 30 degrees to try and get the veins as full as possible. If the patient is unable to lift up their knee so that you can get the probe in behind, they're very weak or the leg's very large, then you may need to lie the patient on their side or even prone in order to get behind to see those veins. Generally, for the very obese patient, I'll tend to roll them towards me. If I'm still struggling, I will try and get the patient to sit up with their legs over the bed, and this is what I do routinely if I am trying to look for calf veins. Now, one of the things to remember though is you need some pressure in order to get nice crisp images, but if you have too much pressure, you'll actually compress the vein and then you won't be able to see it. And that can either be from the probe or even just from the leg resting on the bed when you're talking about the popliteal and the calf veins. So, when we see this, what else are we looking? What's the appearance of some of the other causes of the swollen and tender leg? Well, the first thing is, if you see a clot, you have to consider, is it new or is it old? So particularly in the patient who says they have had a previous clot, this can become very difficult. If you get a DVT, then 50% of the time it will resolve fully after 12 to 24 months and you'll go back to a normal appearing vein. But in the other 50%, it won't. And trying to determine is there new clot on a background of old clot tends to be very difficult unless you have to have an ultrasound that was done after the end of treatment, which is why some places do this routinely. There are some features that will help you determine the chronicity of a clot. As we mentioned earlier, as the clot ages, it becomes more echogenic, more dense, and it shrinks. And so on ultrasound, it appears brighter. There may be areas of calcification. Because there may have been partial resolution, you get discontinuous areas with intervening normal vein, or maybe a serpiginous recanalization through the old clot. And also they're often described as appearing more adherent to the vein wall. That's a very subjective finding and it is something that I would tend not to comment on very much. Overall though, as I said, this is a difficult thing to do, and generally if you're just beginning, leave it to the experts. What about superficial thrombophlebitis? Well, this is not an uncommon diagnosis, and there's thrombosis of the superficial veins. And the ultrasound signs are really the same as for deep venous thrombosis, but of course you're looking at a superficial vein. So it tends to be the saphenous vein in particular that we're concerned with. And that's because even though historically superficial thrombophlebitis was always considered a fairly benign condition, if you actually look at patients who've got long thrombus in their saphenous vein, then 4% of those patients actually had symptomatic pulmonary emboli at the time of presentation, and 10% of them also had deep vein thrombosis at the time of presentation. If you treat patients with superficial thrombophlebitis with low molecular weight heparin, 10% of them can progress to develop a deep vein thrombosis or a pulmonary embolus. And in particular, those patients who've got thrombus near the saphenofemoral junction have a very high rate of progression to deep vein thrombosis. So pretty much everywhere will automatically treat these the same as deep vein thrombosis. So if you've got a long segment of clot or clot near the saphenofemoral junction, then these patients probably are going to need treatment. Now, one thing that you do need to bear in mind is that the studies that most of these figures are based on are of patients who have been referred to specialist clinics, and therefore there is probably an element of selection bias towards those patients who have a higher risk of clot or a higher risk of progression. For example, those patients who have cancer, active cancer. But nevertheless, if you see superficial thrombophlebitis, I think it's very advisable to look at least at the proximal deep venous system and to note where that thrombophlebitis is, how long it is, and is it near the saphenofemoral junction. So, what does that look like? Well, this is a patient who has thrombus in their long saphenous vein and also clot in their common femoral vein. This is from somebody who presented with an area of tenderness in their calf, and here we see this is the vein, it's swollen and it's full of echogenic material. But this was a short segment, it was isolated to the calf, and so this was treated with non-steroidals. We can also look for signs of cellulitis. This is a common differential for deep vein thrombosis, and in this case we look for soft tissue edema. You see fluid that spreads through the tissue planes, and it's often described as a cobblestoning appearance. As well as that, we may see associated lymphadenopathy. So here we can see the fluid in the subcutaneous tissue giving this cobblestoning appearance. When we look higher up the leg, we see here is an enlarged lymph node. This is the hilum, this is the periphery of the lymph node. So moving on, Baker's cysts are not uncommon. They usually present with patients saying they have a tenseness behind the knee, and these are a fluid distension of the gastrocnemiosemi-membranosus bursa. They are found posterior to the medial femoral condyle, and usually if you look carefully enough you can see a little extension which points towards where the knee joint is. This is what they look like, fluid-filled space, and here this a little neck that dives towards the knee joint here. If we look longitudinally, they can be quite long. This is an unruptured cyst. If they rupture, you can then also see fluid tracking down between the intramuscular planes. Muscle hematoma can be seen within the muscle. It's a collection. Depending on the age of the hematoma, it might be hypoechoic, isoechoic, or hyperechoic. And this is quite an extensive hematoma. We see all this blood sitting in the calf here. Now I'm just going to touch briefly on upper limb veins. The anatomy, we have the basilic vein and the cephalic vein are the superficial veins. The deep veins are the radial and ulnar veins, and they're usually paired, which then join to form the paired brachial veins. There's usually a single axillary vein, although it may be paired, and then a single subclavian vein. And this, of course, runs under the clavicle. And this makes it technically much more difficult. Firstly, the axillary vein may be difficult to see because of overlying either breast tissue or muscle. And once you look at the subclavian vein where it's gone beneath the clavicle, first of all, it is difficult to see. But secondly, you're not going to be able to compress it because of the clavicle. And so you have to use the Doppler features that we discussed before in order to determine if there is a thrombosis or not. So technically, much more challenging. And when you're beginning, I'd suggest leave this to someone with more expertise and experience. So just to recap some of those pitfalls. If you've got too much transducer pressure, it can cause the veins to be collapsed and you won't see them. If you are using the Doppler signs, you have to make sure your settings are correct, otherwise you may fail to show the flow that is actually there. Venous anatomy is much more variable than arterial anatomy, and so in many patients there will be duplicated veins. Most commonly the popliteal vein, but also the femoral vein this can be found in. And in that situation, if one of those is thrombosed but the other is patent, you may not detect it unless you're looking carefully. So you have to, as you're scanning down, if the vein branches, you have to look at both the branches. The other clues are if the vein just appears to be much smaller than you expect, then that can be a suggestion that there's actually a second one, and if you can't see it, maybe that's because it's full of clot. Also, if the vein is in an unusual position, for example, normally in the popliteal we've said that the vein is superficial to the artery. If it appears deep, then you've got to consider maybe it was duplicated and there was actually one that's superficial and one deep, and that one of those is now thrombosed. If you're having trouble putting enough pressure on to compress the vein, for example in a very large leg, don't be afraid to use two hands and with your other hand reach behind and push up from below. Finally, if you've got a very large patient then occasionally I've seen people mistake the long saphenous vein, and because there's a lot of overlying fat tissue, they think, oh, because of the depth, it must be the femoral vein. The femoral vein has the artery running next to it. The saphenous vein doesn't. So if you're unsure, look for that artery. Now, putting the ultrasound exam in context, there are a number of controversies that I think are worth discussing. The first of these is that you'll hear a lot of people talk about the two-point exam. And people describe this as you put the probe on at the groin crease and look for compression, and then you put it behind the knee and you look for compression, and you don't need to do anything else. It's a very quick exam, obviously, and technically it's quite simple to do. But if you look at the accuracy of this, the literature quotes this as being, first of all, between 70% and 100%. In fact, there's now even a more recent report that in an intensive care setting it was as low as 50%. The other thing that you need to bear in mind is that the papers, many of the papers that originally described this two-point exam, although they used the term two-point, in fact, what they were looking at was two areas. The upper area from the common femoral vein to beyond where the deep femoral vein joins. And so that's an area of a number of centimetres. And the popliteal vein, which they examined right from the proximal popliteal vein to the distal popliteal vein throughout the full popliteal fossa. So it wasn't really an exam of just 2 points, it was actually more 2 areas. So because of this and because of the variability in the literature as to the accuracy of this technique, I would suggest that you should actually scan the full length of the femoral vein. The area between where the deep femoral vein joins and the proximal popliteal vein is usually fairly simple to scan, and you can do this whole area in only a minute or two of extra time. And for me, the increase in sensitivity that I will gain is well worth that extra minute or so spent doing the exam. So this is what we are going to teach you in the course. Finally, what about the calf? I've touched on the calf a little bit, and I've said that technically it takes a lot more time and expertise. Now, there is still argument as to whether or not you should examine the calf at all. The UK guidelines and the American College of Chest Physicians guidelines generally recommend that you don't look at the calf at all. However, in many Australian settings, we do, in practice, treat isolated calf DVTs, and therefore we will look for them. As background, about 15% of isolated calf DVTs will extend in more proximally or go on to cause a PE. And so many people say that that is sufficient to justify looking at the calf. You will need to see what your local standards are. Some people will risk stratify patients into high risk, such as those with active cancer, and treat those and not treat those at low risk, such as those who have recently had an operation but are now mobile, or had a cast that has now been removed. So there is some local variability. And I think when confronting this, I think what you have to do is put this in the context of what question you're actually asking. So for example, if it is a high-risk patient, then yes, I will look at the calf because I know they have a higher risk of progression. If this is going to be a definitive investigation and I am not going to bring them back either for a comprehensive scan or for a repeat scan in 5 to 7 days, then I think you need to be a lot more cautious about excluding the calf. If I'm looking at a patient and I see an alternative diagnosis, then maybe I won't look at the calf. And if the symptomatology is all isolated to the thigh, then I think you can reasonably argue that you don't need to look at the calf. The second area of controversy that I want to touch on is whether or not you should examine the opposite leg. This is based on the fact that up to 30% of patients with a DVT in one leg will be found to have a DVT in the other asymptomatic leg as well. And therefore, if you've done a scan, if that patient then develops symptoms in the other leg, that can be really useful, because that can determine whether the clinician then says, no, look, this clot was already there, therefore I don't need to adjust my treatment, or say, no, this wasn't there, this has now developed. So this is now a patient who's developed thrombus whilst on treatment, a treatment failure, and that has significant implications for the ongoing treatment of that patient. Finally, as I've mentioned earlier, it is often useful if a patient represents later to have had a scan that has been performed at the end of treatment, so that you know what the new baseline was. And therefore, some places will do this, some places will not. And once again, I think you need to know what your local policies are and follow those. Nevertheless, there are still, I think, many cases where a proximal leg scan is very useful. First of all, if it's positive, it tells you the patient needs treatment. But even if it's negative, then I think it still has utility. First of all, as I've mentioned, if the symptoms are confined to the thigh, then a negative proximal scan, I think, is probably all you need. If you make an alternate diagnosis, for example, you diagnose a Baker's cyst, then I think it's quite reasonable to say, so long as the symptoms are consistent with that, that we don't need to look for a calf DVT. If you are going to do this and then bring the patient back for a formal scan, say in the next day or two, then it can help you avoid unnecessary treatment with usually low molecular weight heparin pending that comprehensive scan. And even though low molecular weight heparin has a very good risk profile, it still has side effects. And there are patients who will be given heparin who will suffer a complication and then be found never to have needed that heparin in the first place. And so we can avoid that in these patients. We can also, I think, use that to avoid calling people back in, or to have patients hanging around in the department for hours waiting for a formal scan. If you can do this and say, look, there's no proximal scan, let's book them in to a time tomorrow which is more convenient for everybody. I think that's a very useful role for the test. And similarly, if the patient is low risk and the D-dimer is unavailable, or for some reason it's delayed, it's going to be hours and hours and hours, then it may well be much quicker for you to do the ultrasound scan in the department and then allow the patient to be discharged with a view to bringing them back maybe in a day or two for a comprehensive scan, or if the proximal scan is negative and the D-dimer eventually comes back as negative, then you may say no further imaging is required. If the D-dimer comes back as positive, then your local policy may be that they then get a repeat scan in 5 days. Again, you have to put this into the setting of what is usual practice at your hospital. So, in conclusion, scanning for proximal deep vein thrombosis of the leg is usually simple and it's usually very quick. It is highly accurate to exclude proximal DVT. We use compression as our gold standard, and usually Doppler doesn't add that much in that setting. But if you're looking at performing a more comprehensive scan, and if you're looking at learning how to do upper limb DVTs, then you're going to need to know how to do the Doppler tests as well. Controversy still exists, and there is a lot of variation internationally as to whether you need to investigate and treat calf DVTs. So you are going to need to work out how this test fits in with your local practice and guidelines. Thank you.